We don't know. Like this, we had, you want to?
Yeah. So, for the last week, I've been doing some real teaching and talking to people about
Kids, go to the
life.
Go to the
So, for like the last 7 months or so, this
What was that?
Okay. So for the last 7 months or so, this has been something that I've been really diving into and talking with NIH offices about. And as a mother, okay, so I'm just a mother, but as a mother, and I'm fourth generation mother in my family to have a child with sickle cell. So when I say I have lived with sickle cell all my life, it's been all my life. I was really, when I found out about bone marrows and marrow transplants and that they would do them for free and everything, I was in shock that we didn't take them up on it. And then I started really thinking about it. Part of it is that when our kids are little, like you said, they're running around, our kids are healthy, right? We have no idea, as a new mother with a child that's recently diagnosed, you have no idea about this journey that's about to happen, right, in this life. So I think that that's the number one reason that you aren't getting people coming in and inquiring more and taking up that opportunity. And so we're really going to try to get that word out, that we need for our pediatricians to really have an understanding of the disease profile. And I think it's a matter of education.
Dr. Robinson, I think to specifically answer your question, it has not been presented to us. A lot of us go to have our children have frequent visits to the providers, the hematologist, and it's just is not being, the information is not being presented to us. I first learned of bone marrow transplants at a children's education day. And so I immediately, at the time, my son is 10 now, but at the time he was about 4 years old. I was told that he hadn't been sick enough for him to be considered. That there was about a 5% mortality rate, and I'm not looking, so there's 95%. He's 10 years old now, but at the time, 4. And I learned of it as education.
And I will answer that. When things are in clinical, when they're in trials, they do have certain eligibility criteria that they have to follow. And you're absolutely right. The trials, usually in the beginning, you had to have severe disease to have a loan.
Right. Well, I was really excited because I have a unique situation. I think my son has a fraternal twin that has the trait. So I was like, great, we could possibly have a perfect match here. So, but at a very early age, from the age of 9 months to 2.5 years, my son was on chronic selection. So they tested the twin and said, he's not a complete match. He's only a 67% match. That's why when you mentioned hapla, I'm like, okay, so 50%, he has a 67, well, had, I don't know if there's still a 67% match, because they're both 10 now, but I found it very interesting. And so that hapla, are they doing that here in the States?
Yes. Yes. St. Louis is, well, a lot of places. St. Louis is one of the places it's doing. Okay. This is, I'm just going to show you this quick video. Like I said, I'm not above stealing things. Dr. Bassine does transplants at Vanderbilt with adult patients, and he gave a lecture. This was just, we gave his permission, of course, to use it. But this was just a question from one of the patients at the
what's your opinion on stem cell transplant for adults. So if you look at malignant diseases, the amount of stem cells you get from a cord from a child is usually not enough to transplant an adult like you. So what has been happening is in malignant diseases, like cancer, what people have been doing is combining two similar cords. And if you look at the results, it can generate a graft-versus-host disease, which you don't want in sickle cell disease. So one strategy, which is being explored, but I would say we need to sit back for now and see what happens in malignant diseases. It's called the expanded cord protocol. So there are now studies looking at what you just said. You have a child, you get cord blood. It's good for you. They take it to the lab and expand this lung and then use it for you. So we need to see over the next few years where that is going. And if it works without significant graft-versus-host disease, that even opens up the opportunity for it. Oh, the African hepatitis. Gene therapy is also in the wings. I think that's fascinating. That might keep me on the job.
So he is doing HAPMO on adults with sickle cell disease at Vanderbilt. It's a consortium of institutions we're working with to doing HAPMO. Just going to go through the rest of this very quickly. Harvesting to harvest, people have asked, what about the donor and what happens with the donor? They basically, it depends on how much they need. In adults, the donor would be prone. You have two people on both sides. They take out the marrow. It can be as much as 200 sticks, depending on the feeding. And because they can only take out about 5 cc's or so at a time, so if you figure you need about 10 cc's per kilogram, per 2 pounds of body weight for the bone, for the harvest. And so in order to get that, they have to get a lot of sticks to get a lot of bone marrow. And one of those bottles of water is about 500 cc's. So if you need a liter, you need sticks a lot. But children recover quickly. If the children is a donor, they can be running around the next day. Adults take a little longer. They might hurt for a week to 6 weeks out. No heavy lifting. And there's also peripheral. You can get injections. The donor can get injections to basically kind of force their stem cells out into the peripheral blood, and they can collect it kind of like you do with erythrocytosis. So, 2 minutes. All right. And I'll just go back to this quickly. How do you get the bone marrow? It's basically like an infusion. So it's not an invasive type of operation that they're going in. It's basically like a blood transfusion. So we talked about complications. It doesn't work. So you end up with sickle cell disease. You can get infection. You can have graft-versus-host disease. It's basically where these donor cells are attacking the immune system. It's acute usually happens within 100 days, and usually they can handle and correct acute. Chronic, by definition, anything after 100 days. Chronic is horrible. It's where it's attacking your body all the time, and it's the cases that I've seen, in addition to organ damage, it's visible outside. It attacks the skin as well. You can have changes in color of the skin. You can have rashes all over the body. It's a horrific disease. And then you have the side effects of chemo and radiation, depending on, again, they're getting less of these now in the new regimens, but infertility could be a possibility. This doesn't happen all the time, but it could be, so you have to think about that. And just nausea, vomiting, just radiation, chemo. So before the transplant, these are things to talk about. First, you have to find out if you're eligible. So you have to have knowledge. And I tell people knowledge. You know, the internet has all kinds of stuff. Ask your doctor about it, look it up. You know, ask questions. Then there's a cost. most insurance plans will cover bone marrow transplant now. Early days they didn't, most of them will, but it's still significant. If you have insurance like mine, they pay 90%, we pay 10%. 10% is a big cost. So cost, risk versus benefit, you know, do you want to risk that mortality, graft versus fertility, separation from your family and friends? Usually you have to be isolated at least a month or so in the hospital itself, and then after that, anywhere from 4 to 6 months, you have to stay away from your family, your friends, because they might have infection that they can give to you. So it's substantial work. If you're working, you're losing money from the job. So it's a lot to think about. You want to discuss it with your family, other patients who've had this, you know. And I always like to talk to people who have the good and the bad, if it's possible. Research, clinicaltrials.gov, you can go there and see all the research. Of course, your family, and I'll tell people to talk to a psychologist, just talk to someone. You know, we, as a whole, tend to shy away from talking to a psychologist about issues, but, you know, sometimes you just need to talk to someone who's not involved. And is not getting back. Just get the chance to talk. Okay. I'm just going to show this one thing and I'll be done. This is from, this is Mark Yancey. He had a bone marrow
transplant. A whole lot about the experience of a transplant. People would go something like, I got, radiated, and it came and they told me them to destroy my bone marrow system. They were going to take out my immune system, and so forth and so on. All true, but these are things that really are beyond what the conversation should be until you even get to the point of knowing, is a transplant for you, can it work for you, so forth and so on. I can say that the transplant was definitely an experience like no other. I mean, these are serious things we're talking about in terms of being immunosuppressed, losing your hair, being confined to a space for months that you can't get out of. These are all very serious things. But if I'm you, there's more that will need leading up to that point that did not know that they even existed than it is for me to talk to you about that experience. Because for me to talk about that experience in and of itself, you have to have the transplant yourself to understand what the experience is about. What I would have liked to have had before that is for someone to have helped clear up for me why the disease that I have is so serious and such a life-changing disease to have at every moment. That why it is it's just so moving as a bone marrow transplant.
And he has had, just as a general aside, he's had several hip replacements, he's had infection, he's had cord infections, he has had a difficult cord, but he said he wished he had done it a lot sooner. Even after the transplant, I was talking about the damage doesn't go away, he had to have another hip replacement after he had the bone marrow transplant. But he still, as a whole, said he would have done it. So I'm going to stop there.
Very quickly. Okay, so in discussing sort of the prospecting conundrum of bone marrow transplantation in very young sickle cell patients, it reminded me of the fact that women who test positive for BRCA1 and HER2 are sometimes now electing to have preventative mastectomies. So that's another very, we perceive it as drastic surgery for something that hasn't happened yet, but they believe that in the future it would be worth the risk to avoid it. And the reason that they're able to make these decisions is because they have the information up front, not just from their individual healthcare provider, but in society overall. And I think in sickle cell, we're lacking information flow from within society to spur, a patient to bring the conversation up with their doctors. And also doctors are not necessarily initiating the conversation around bone marrow transplantation because they their minds these criteria. Well, you're not that sick, or this, reason or that reason, and really it should be up to the patient.
And that's pretty much down as a criteria now, by the way. In the early childhood criteria, but now pretty much. Yeah, but, and I absolutely agree with you, knowledge is key. You have to have knowledge, but I think there's a big difference when you're making a decision for yourself and when you're making a decision.
What is that?
That has another indicator of guilt. And I know, tell quickly while she's loading that, a parent who had a transplant, had a child who had sickle cell disease, had a transplant worked well. Had another child, and that child also had sickle cell disease, and the child died. The level of grief that she had was tremendous, and she still hasn't gotten over it. So it's, that's a difficult call, but you're right, knowledge is the only way you can make that call. If you have to have knowledge.
Yes, I think it's a multifaceted thing. It boils down to lots of different things, and I think parents, even though they have a hard time gauging the future benefit, they know for sure about exactly what you're talking about. They know that they will get it.
I agree wholeheartedly. Knowledge. Everybody should have that knowledge and should have that option to make that choice.
Thank you so much, Yvonne. That was fantastic. So next up, we are breaking into our breakout sessions. And so for those, this room will be navigating the adult healthcare system with Coretta Generette. For those of you that are interested, you can also go to Truesdale Estates for financial planning with sickle cell disease. Dr. Trevor Thompson will be in there. He is an individual living with sickle cell, and he will discuss the benefits and how we can go about managing our finances with this illness. So that will be across in Truesdale Estates. Afterwards, we encourage everyone to give them your ticket, and the buffet will be set at Felice, which is where our platinum sponsor, Global Blood Therapeutics, will be hosting lunch. So please, after you finish your session here, head on over, grab your food, and head on into the lunch area so that we can get started. So now is the time for those that want to head on over, please do that. And Coretta.
I think when we come back from our breakout sessions, I couldn't have it all the way set up because we're about to leave right now.
All right, that's fine. Well, I think there's one in here now. Let's go stream that.
Oh, okay. I think it would be. No.
Maybe else.
Pam.
I am very, very pleased to introduce Coretta Generette. I met her through Snapper. She was the former president of the International Association of Sickle Cell Disease Nurses and Physician Assistants, and it is. And today she is going to be presenting on navigating the adult healthcare system. We know how difficult it can be. In the pediatric system, there's a session on that tomorrow. It's a very different experience from the adult system. So please join me in welcoming Dr. Generette, who is also a nurse and has been on the floor and has lots of experience that she can share with us on navigating the adult healthcare system.
I want to make sure I know how to move these slides forward before I start. Okay, so hello everyone. It's my pleasure to share with you some thoughts as both a nurse who's actually taking care of patients and as an academician who takes students all over the hospital. So I see patients as they're in the emergency room and outpatient settings,
and in inpatient settings. And also as a researcher who has actually done research regarding sickle cell for many, many years. I first began with an interest in sickle cell as an oncology nurse. At that time, more than 20 years ago, most of the patients with sickle cell were cared for on an oncology unit. I loved oncology, but I was just completely baffled as to why I could call a physician about an oncology patient and there was no question, give them whatever they want, add this, add that. But when I called about the patient with sickle cell, it was, don't call me anymore, I'm not giving them anything else. Those types of responses that nurses have to be the buffer to make sure that you get what you need. So anyway, when it was time for me to advance my education, I chose to do my research in the rest of my career, what I'm going to dedicate the rest of my life to as a researcher in sickle cell as opposed to something else. So, we know that sickle cell was first diagnosed in 1910. It's not, it moves here but not there. Is it changed that? So there's some disconnect between this and that. I'll keep talking. So we know that sickle cell was first diagnosed in 1910, but unfortunately, history has not proved as helpful for sickle cell disease from my perspective. So the picture that I'm going to put up is from at the University of North Carolina, our 100-year celebration, where we actually, in 2010, we actually celebrated the 100-year anniversary of sickle cell, and it was the changing face of sickle cell, where we had lots of people. We had lots of pictures of people with sickle cell, etc. So even though we've known about sickle cell for so long, even in the short individuals with sickle cell, not much has changed. Like I said early on, patients were stigmatized. There were delays in care, this, that, and other. And still today, I go to the ED, see students, or with a patient, or talk to patients, and I see the same thing. So if you don't believe me, and I know you do, that there's still issues, then consider these words from nurses. It moved too far. I think it's on a timer. It has a line of the phone, but I didn't do that. There's something wrong. It's not where I want it to be. I'm on slide 3, and it is not. And I haven't pressed it. I'm working on this one ahead. Sorry. So I'll read you the nurse comment. Nope. So, consider a nurse that told me this anonymously. Rating pain at an 8 out of 10 when the patient is laughing, talking on the phone, and socializing with friends does not warrant additional doses of narcotics. There needs to be a better gauge than what the patient reports pain to be. This was not. So as a nurse and a researcher, that's very problematic. That's very problematic and relates to the stigmatization and the dehumanization that patients face when they actually enter the healthcare system. You can leave on that matter or you go forward. So, when I see the outline I want to think I want to cover are things you need to know, like Yvonne was saying, you need knowledge. You need knowledge of sickle cell in general, but you also need knowledge of your body. And then when to access the healthcare system, and maybe the novel approach you might consider to actually navigate the healthcare system. And I'll also go back to something that Dr. Bailey said yesterday. What I'm going to present to you is not necessarily right, but it's the actual reality that patients with sickle cell live in. And if I have to give you some context, it would be from the Black Lives Matter movement. Basically. Black Lives Matter movement. We know that everybody obviously with sickle cell is not black, but there's some quite interesting commonalities between what goes on with patients with sickle cell. So if we have a slideshow, we cannot advance. So, knowledge about sickle cell. Things you need to know are sickle cell, your sickle cell type. You would not believe the patients that I still interview that do not know their actual sickle cell type. I was very impressed by the lawyers I met yesterday who actually were talking about their sickle cell type, and they weren't even standard most likely sickle cell types. They were talking about I have D, and I know somebody who has E with that number. So, also making sure that you know. Also need to know your baseline hemoglobin, know your medications and who you're taking them, know common sickle cell complications and those complications that you have had. An example I would give related to the complications is acute chest syndrome. We know that's the #1 cause of mortality in adults. And you have similar symptoms to what you had before, you would be actually doing your provider a favor by saying, I've had acute chest syndrome before, it feels like the same symptom, because it actually kind of narrows down the possibility that you kind of give that provider a starting point. With transfusion history, that's very much related to baseline hemoglobin. We know that if you've had at least 10 transfusions in your lifetime, you're at risk for iron overload. So if you know your baseline hemoglobin, you may not be necessarily a candidate to give transfusion, but your provider, if that person is not knowledgeable about sickle cell, may actually want to give you one. Prime example, this happens too frequently, even today. When we know so much about sickle cell, someone with sickle cell who has a baseline hemoglobin of 8 goes in to seek care from a person that's not their normal provider because they just happen to be in that situation, and the provider automatically wants to transfuse them because they have some objective data that they can say, oh, I'll give you some blood. Your hemoglobin is only 8. The person may not necessarily need blood. So if you are knowledgeable and know your information, then you can actually avoid that. Know your body. What are your actual triggers? What are the things that lead to you potentially having sickle cell crisis? We know that there's some stressors that cause sickle cell, dehydration, infection, if you're not low oxygenated, changing altitude, etc., temperature changes. People have told me about, oh, I tend to have a crisis if I go swimming. Some people are relaxed when they go swimming. It actually makes them feel better. I would assume that has a lot to do with the temperature of the water also. So just be aware of those things. Know your medications. I can't stress that enough. Dr. Ifyas also yesterday talked about having an actual pain plan. To me, it's a little broader than that. You can have a pain plan, but if you actually have an established relationship with your provider, your pain plan should be embedded within a complex care plan so that you have more holistic care. But you should have some type of action plan in mind when you seek care. If you don't have a contraindication for taking anti-inflammatories such as renal disease, it may be helpful for you to take anti-inflammatories as a start or along with your opioids to potentiate those. And I know you all know about drinking fluids, rest and reducing stress when possible. And that includes eustress and distress. Good things and bad things. I've heard people say that, oh, I was so excited about going out of town to a wedding, but then I got sick. So you have to be aware of those things. And the relationships among stress, swelling, inflammation, and pain. So, anytime you have a question, just stop. Yes?
You said temperature changes, and you mentioned swimming. As an adult with sickle cell, SS is my phenotype, I found out that when I was younger, and I did most of my swimming, and was having pain crisis, I didn't really know what it was. Now, every medical doctor, or I don't understand why no research has ever been done. Chlorine is in most pool water. So what I did is, I was traveling out of the country. I was in Jamaica, and I went to Dunn's River Falls. And the lime asphalt is similar to chlorine. So, I had a pain crisis. So, as an adult, I went back to my physician, my hematologist, and I said, listen, I think chlorine, anything with lime asphalt in it, has something to do with patients going into crisis. He said, well, it's not documented. I said, I'm very much aware it's not documented. That's why I'm bringing it to you. And I know for a fact, now I swim in saltwater pools when I'm not at the beach or in the ocean. And I have no problem dealing with salt water. So I really think, and you know, it's one of my things I'm working on and doing research is, I think researchers should know that chlorine, lime asphalt that get in your joints, we all know that sickle cell pain is attributed from being in your joints in certain parts of your body, whether it's the bottom of your feet or the top of your head. And that's something that people really need to know that's the truth. Because I tell all my clients, if you're going to swim, your child is going to swim and they're going to be in chlorine-filled pools, make sure when they get out, they shower very well with soap and water, getting all that chlorine off of their body, so they most likely will not go into the crisis.
So you make two important points. One is knowing your body, knowing what you should avoid, because things can be individual. And the other major point you make, things can be multifactorial. It could be a combination of the chemicals and the temperature of the water.
Right.
And the third point, which you didn't make, but I will make as a researcher, that there isn't enough research in sickle cell in general. And things like what you bring up are going to be low-hanging fruit, that is going to be very hard to get research studies that are actually going to move the evidence forward in those areas, because those types of things are not well received per se. They should be, because it's like things coming from the sickle cell community are the things that we should focus on, but sometimes they're not. But thank you. So, if you know your body, you may be able to pick up some of these warning signs and complications. So if we match these two for the sake of time, when you think about it, acute chest syndrome is very similar to pneumonia. When you get acute chest syndrome, you may have a fever, you may have shortness of breath. Neurologic symptoms may be indicative that you have an evolving stroke. So things like weakness, slurred speech, visual changes. And we all know that priapism is a significant condition in men, but sometimes it's not taken seriously. We see those lovely commercials on TV about a prolonged erection for more than 4 hours. I mean, someone with priapism, if they don't seek care, they can have the same outcome as someone who took a medication and lead to reproductive issues, etc. Now, this slide was shared with me, like far things that's already well done, from the director of transitions at Duke. And like I said, I'm from UNC, so I don't reference Duke very often, but anyway. But some great colleagues on there. So Dr. Nimmershaw is the director of transitions, and he actually has a whole set of slides related to what people should know at different ages. And I just pulled this one slide because I think it was a great depiction of some of the important lab values that individuals with sickle cell should know. Are all of these pretty familiar to you? Most of you? The hemoglobin, MCV, retic count, white blood cells, and platelets. And then related to transfusions, patients should have an idea of what their serum ferritin is, that's the SF, and then LIC is your liver iron concentration, because those give ideas about if you are in need of chelation therapy and such. So keep those things in mind. And he, in his work, he says by the age of 15 to 16, all of us should, people with sickle cell should have a good idea about this information. So obviously all of us, the adult population should know all of this already. So now, more specifically about care seeking. So, when do people with sickle cell actually decide to seek care? Are you all aware that they're typically, at least documented, that there are phases of a sickle cell crisis? They're whole separate different things, but all of it kind of the same. Pre-pain or prodromal phase, the initial or infarctive phase, and then the established phase, where you seek care, and then the resolving post-crisis phase. This work has been done by Dr. Samir Balas in Philadelphia, and also a nurse scientist, Euphemia Jacobs, has done some work in this area. Most people with sickle cell do believe, at least in this small study that I did, believe that there are phases, even though there are other people that said they don't actually go through phases, they just automatically, they may wake up hurting. So they've already skipped this prodromal phase, per se. So once again, it's about knowing your body. Some people receive cues and signs from their body, and it's probably the same people who say they go through phases, that they have these cues and signs. What are some of the cues and signs that people talk about? Joint pain, back pain, headache, fatigue. They actually, if they weren't as jaundiced, they may become more jaundiced. So again, all along the phase of knowing your body. The issue comes in with, that I want to focus on, is about care seeking and when you actually seek care. So in this study, the majority of people with sickle cell pain or crisis actually did not seek care until their average pain was about an 8.6 on a scale from 0 to 10. We know why. Because these factors, 3 reasons that you see here. They've been taught to or try to manage their pain at home as well as they can. They want to avoid the emergency room because of the way they've been treated in the past, and they want to avoid potential admission. We know none of these resemble people that are drug seeking, correct?
Right.
But you still get labeled. So if you keep that in mind, a pain score of 8.6. Now, I know a pain score of is much different than a pain score for me, because people with sickle cell have lived with pain. So now, if you think about communication, which is the key to navigating the healthcare system, you have to have knowledge and you have to be able to communicate in a credible way, not because it's right, but because that's reality. So, when it's a talk to your hand time, other people don't do that anymore. I do it to her. What are the times when you actually have problems or difficulty communicating? When you're hungry, when you're angry, when you're lonely, when you're tired, and when you're in pain. Sickle cell patients, when they seek care, are in pain, and the longer they wait, the angrier they get. So what is the correlation or the relationship between communication and being more stigmatized and more dehumanized? The less your ability to communicate, the more you're going to be stigmatized and dehumanized. So the angrier you get, the more likely you are to not be able to communicate, the more pain you are in, which is because you haven't been treated. So it's almost like a cycle that you can't get out of unless you have some type of technique in order to navigate the system better and get what you need before you actually have a whole lot of pain. So, consider this. Who wants to interpret that for me? A stitch in time saves 9.
Well, this is my grandmother's favorite saying.
Interpret it. What does what she mean by that?
It means take care of things when they're little before they get big and very difficult to take care of.
Right. If you get a little tear, if you don't take care of it, it's going to be a big rip soon. So apply that to sickle cell. If you can go in when your pain is a little lower, then you might have potential to avoid some of the stigmatization because you can communicate your needs better. Now, I know that's a whole paradigm shift, and it's going to take providers to understand what it is you're trying to do, but perhaps that will come about because of communication. Now, here's the thing to see if this actually works. And I bet it will not. Yeah. Did you have to do something different?
Yeah.
So this is normalization.
Hey, see you back again today. I'm Dr. John. You remember me just last week? Yeah.
organization that embellishes on the stereotypes in care for sickle cell. You have a patient that's seeking care that has a significant level of pain. She can't give the provider what they need, and the provider comes in with some implicit biases and using those stereotypical terms. What if we consider flipping the script just a little bit? What if we try to teach our patients how to use the same terminology, the same way to communicate that healthcare providers use, with the goal of, unfortunately, trying to enhance the patient's credibility when they go to seek care. So this technique is used, it's decreased all kinds of sentinel events. It's the gold standard for communication between healthcare providers. Nurses use it for handoffs. Nurses can handoff meaning when I give my assignment of patients to another nurse. If I'm calling a provider trying to get something, I'm going to go through these things. I'm going to say what the situation is succinctly. I'm going to talk about my background. I'm going to say what my assessment is. And for the patient with sickle cell, this feels like my typical crisis, that type of thing. And then I'm going to give a recommendation. If you give me so-and-so and so-and-so, that's what usually works for me, type thing. So, and you don't need to consider the responses. So what would this look like in that same scenario that we saw the first time?
Hello, Naomi. I see you're a member of this group with hang out after 10 and 11:06. Can you not take care of that at home? Most of the sicklers I see come in here, with a pain level of 9 or 10. So I try to seek care early for my pain. I know my body. I'm pretty good at managing my pain at home, but I try my usual medication. It just didn't work. I mean, I've been hurt and the pain's getting worse. The pain in my leg started a couple days ago, and it was sitting on the scale of 10. It was like I'm headed for a bad crash side. So I wanted to get one. Well, I'm going to have to examine you so that I can decide what I think is best. I just didn't need to examine you, but I hope we can talk about the treatment plan. When I felt this pain getting worse, I tried to get over it and get more through it. I took Percocet last night, and I took Percocet this morning, but when the pain got worse, I just decided to come in. So you only have Percocet at home? Yeah, that's all I have. I want to get something a little stronger and maybe some fluids. I don't know, a horrible crisis is all possible. I don't want to be here in the hospital, but I'm going to just work. That sounds like a reasonable plan. Let's start with an exam, and then you and I can talk about what would be the best thing to keep you up.
So does that sound doable?
I'll need that exam, but I just think at that point, you're seen as a drug seeker.
Right. Because you're coming earlier?
You coming in period.
So anyone else agree with that or have other comments on it?
Basically, this was such a, tell the doctors what you suggest, right?
It's actually, the goal of it is to enhance your credibility by using the same framework that they use. So it gives the same information, and because you've gone in a little earlier, that you actually are able to communicate, and it's a win-win. I see it as kind of half meeting in the middle. While we still work on the providers because they need a whole lot of help, you are kind of meeting in the middle. And I say it's similar to the Black Lives Matter movement, that a black person has to go bend over backwards to not get shot.
I think it's pros and cons to it, because that's basically what I do already. And it's basically who you land in the yard, because I'm a well-informed patient. I have a care plan, so I know the ins and outs of my care plan. And some doctors, I feel, are intimidated or feel like, why is this patient, what do you need? When you're telling them, this is what works for me, this is how you usually get it. You know, some doctors are like, okay, great, and other doctors still will do what they want to do. So I think it's good to do, because some patients will go in and just can't communicate well, get an attitude and all of that. But I feel like you said, it's pros and cons to all of it. But I would suggest it. It works for me for the most part.
Yeah, good. I think that it does have to take a balance, and like you said, depending on who you interact with, nothing is going to help. That just means that you should cross that provider and perhaps that facility off the list. Make sure you follow up with the appropriate letter or whatever afterwards regarding your care. Make sure you fill out those patient satisfaction surveys, etc. But if there's something that may move the pendulum a little bit and make it better for the next person to come in, to decrease those stereotypes related to sicklers and clock watchers and drug seekers and things, then I think that it may be helpful. Yes, ma'am.
So, similar to what she said, it's the same thing. You know, when my son was small, I would keep a notebook, a little journal, and take it in so that I could show them it was charted. We took this at this time, this at this time. And some of them still just take your things and put it to the side. But I'm a firm believer in, I will move my dollars on to the next thing, because really it's about money. So this is not a free service, and it's certainly not free when I go to work, those hours. So go ahead and just change it. Do not be afraid to change.
Or I say, I try to report to that doctor. The hospital don't like to hear that a doctor treats you negatively. Right as soon as they step into your room. And I'm the queen of I will report you.
Oh yeah, I believe in documentation, and now we have the email system, because then people can't say that you didn't because then you have a trail. A few more things. So if we consider using SBAR, or some modification of it, then we may have increased positive pain management experiences. We may decrease the health-related stigma that individuals with sickle cell face, and it's mainly the adults. And then also try to develop some more helping, trusting relationships between nurses and other healthcare providers. And I emphasize nurses here because as a nurse, in the inpatient setting, it's the nurse that's going to be working a 12-hour shift with you. If you have a bad nurse for 12 hours, and by bad, I mean one that doesn't believe you, is not responsive, you're going to have a long 12 hours. But if you can use some techniques to build up rapport with the nurse, etc., you might have a better outcome. And because the nurse is the healthcare provider that's with you, that's the liaison between you and the physician, if you have a good nurse, that kind of in some ways outweighs a physician that's unresponsive. Because now, back in the day, I wouldn't have done it, but my new and better self, if I call one physician and I don't get something, there's a chain of command. Everybody has a boss. So there's the attendant, there's the chief, and there's the chief person over the whole school of medicine or over the hospital. So there's always going up the chain of command. And once they see that you're not afraid to do that, that can also give you leverage. Maybe not today, but it'll help tomorrow. And then a few more recommendations. So, and this also goes back to my faith, but it's our reality in the sickle cell community. You sometimes have to tell the provider, nurse, physician, what they already know and answer the question that they don't have, that they have not asked you. So a common question that I see all the time that's not asked, that should be asked, what are your pain management goals? If you come in at an 8, maybe you don't want to get to a 5 before you go home. Maybe it's a 6. All of that's very individualized. So make sure you have a discussion with your providers as to what your pain goals are before you're ready to go home, both in the ED and in the inpatient setting. Talk about, before you actually get your medication, the larger dose of the IV medication, talk about the fact that sleep does not mean that you're not hurting and that you should still get your pain medication. Nurses, and I just did a service for nurses on oncology unit that we're going to get an influx of patients with sickle cell. Oh, they just want to be knocked out. Well, your cancer patients, you knock them out, they don't even ask. So, if you're in pain, I would love to, if I'm in pain, I would love to get something that helps sleep it off, because maybe I'll wake up more relaxed or whatever. But just because you're sleeping does not mean that you're not hurting. So continue to do assessments, etc. And just because someone's sleeping doesn't mean they don't need more pain medication. So nurses use that as an excuse lots of times not to medicate patients. 1, 2, 3, 4, you can count, you've been taught to count their respiration. And then we have these ongoing talks about the PCA, the patient-controlled analgesia. Patient-controlled analgesia is not the be-all and end-all if the medication is not right, if the dose is not right, if it's not set up correctly. So be aware of what that actually means. If they give you a PCA pump and it has no continuous dose, there's a problem there. You should always have a continuous dose In most cases, you should have a continuous dose and something for breakthrough pain. And then also make sure that you have access to non-steroidal anti-inflammatory. If appropriate, you don't have renal disease and Tylenol, because those things can help. And then the last thing I have at the bottom is know your chain of command and use it. If the staff nurse, if that's assigned to you, is not meeting your needs, there's a charge nurse, there's a director of nursing, there's a VP of nursing, all those things. So start taking some names and sending some emails and following up with people, especially when you're not in the sick mode and you can't do it. When you're feeling good, go back and actually meet some people and talk to them about your experience. They don't know who you are per se when you fill out a patient satisfaction survey, but they'll know who you are when you show up. And then the last thing, hopefully all this together will help us to develop more trust and have better experiences in the healthcare system, and we can transition to a better system for individuals living with sickle cell. So I am going to thank you, and note that those videos I showed you, those were videos that I did with some amateur scripts that I developed along with some professional, some other healthcare professionals. But I actually want to now redo those videos, and I have funds to do that. So if anyone here wants to contribute to those videos by sharing a scenario either in the available for that. And also, if you think that communication may be helpful, if you would like to sign saying that if you think communication would be a helpful thing for you as an individual with sickle cell to learn some more skills, that would also be helpful. So I'll end there and answer any questions.
Do you have any of these?
Go ahead.
I was just going to make a quick comment. I do want to take up your offer to share a story in more detail quickly. I found a situation when my son was young, about age 7, very instructive. We went to one hospital because he appeared to be having a stroke, and we just rushed in without any warning, and we were skillfully ignored. We were triaged very quickly to the back, but then 45 minutes passed and nothing had started. He happened to be visiting me because I was visiting for the summer, and I was able to find his pediatric hematologist from a couple of years earlier, and he told me to leave that hospital, go somewhere else, and to skip admission, go directly to the pediatric ICU, and he ended up having an exchange transfusion, this was 20 years ago, for 6 consecutive hours. And I remember when I left the first hospital, I was upset, shouted, screamed at everybody, but I noticed a dynamic. When a private doctor admits you to the ED, you get much better treatment, and you predetermine the experience you're going to get. Now, often you call a doctor's office, and the recording says that this is a medical emergency, call 911. But if you can get directly to the doctor, and maybe it works better in the pediatric setting, you have a much better experience than if you just rush in expecting compassion and quick medical care, ironically.
Right. And in the adult arena, most people, I always call it the Carlton Haywood video, where Dr. Sophie Lanswan from Hopkins talks about having to call in advance for her patients when you don't have to do it for your other patients, but for your sickle cell. Once again, it's not right, but it's our reality. Until we shift the paradigm, we are always, and I say we as in the sickle cell community, are going to have to do more and different than other people. So.
And that is effective. We just did that with my son. He needed to go in. He called me. I called his doctor. His doctor called the ER and took him right in. Not a lot of questions. But we set that up ahead of time with his doctor.
Yeah.
We live in Georgia, and I'm just totally amazed. I don't think we can do direct admits. They don't do direct admits. Your doctor would say, just go to the ER, tell them to call me, and they met call. So in Kansas State, where you can do like direct admits.
I did direct admit. Like stop and just call, and when you get there, they take you straight to admission, and you go to the room, and they get you started.
I'm from South Carolina. I know Georgia's a little different. That just depends on the conditions and Because a lot of physicians now don't even have admitting privileges per se. The hospitalist is going to take care of you when you're in the hospital. So you're not admitted under your primary provider's name even, you're care provider hospitalist, so, which has other challenges. Yes, ma'am.
Hi, my name is Kelly Russell, and I work at Children's Hospital Los Angeles. And I just had the privilege, we are doing a quality improvement project. We are trying to improve our care for patients who are transitioning into adult care. So I've had the experience of calling some of our young adults. I've now talked to 33 people, and I hear this story 33 times. Yes. Basically. I mean, I'm exaggerating, but not really not live action. So I'm just wondering, on the other end, is there any coordinated national effort to somehow educate emergency department physicians and personnel? I mean, I know there's the National Association of Emergency Department something.
Yeah.
And how can we get there and turn this around, because it's too long, it's too much, and I can't cry anymore.
Right. So there is an initiative underway for that. Several initiatives actually. I know I could mention this again. Dr. Kalatanabe at Duke is actually a nurse who's very connected with the Emergency Nurses Association, and I know they're doing a whole lot of work. We know that patients with sickle cell are supposed to get triaged at a certain level, but they do the okey-doke. They triage you and then they make you wait. So they have checked the box that they have triaged you, and then you still end up waiting, or there's a delay in getting your pain medication or dose, etc. So there's a lot more work that needs to be done. But because the work on the provider side has not gotten us what we need, I decided to do my research on the patient side to say, well, regardless of what situation you come in contact with, you can still put your best self forward. So they can't stereotype you and say you did this, this, and this. So that was mine. Ms. Shirley Miller.
I have not been in the hospital in a very long time. It's very, very difficult to do what you ask on a national level, especially if you're in an academic center where people come and rotate through the ER all the time. And so you're going to change doctors all the time. It's very hard to do. So I think that you do have to do it on the patient level and teach patients how to deal with it and how to maneuver the system, because you really can't depend on the doctors. I mean, we do training. I'm in Charlotte, North Carolina. We train at ED. We've been there so many times, and after a few months, it falls back to where it was. It depends on the doctor, but it also depends on if you have a comprehensive center where somebody is really understanding about sickle cell and knows about sickle cell. So it's different at every center.
So we're going to have to cut off now the great grand poobah, Dr. They're giving me the side eye. So, but lunch is available in the foyer right outside this room, and then you need to go over to Los Feliz.
Los Feliz. And Deborah Taylor, I'm not sure, whoever's Deborah Taylor, please see the registration. Everyone else, grab your lunch ticket. They're going to collect them right out here. Grab some food and please head on into Los Feliz. Thank you.
Thank you all. And find me if you're interested in sharing your story and or signing that you think communication skills training for individuals with sickle cell can be helpful.
Thank you. Thank you.
we went to, my doctor and I went to, there's a lot of patients there. We were making her, and one of the docs in emergency was used to work with us, and so, you know, we figured we had it, and we went to the very nice. And he said, you know what, he said, I'll take this, he said, but I'll tell you now, he said, none of the docs, because we had a protocol. But now the one good thing, Ash is picking up the thing, and Ash is starting to see the emergency without involving us in the process. And so, and where they might work somewhere else, they don't necessarily work in the PR. So how can you make rules without involving us? And so it's at least good to involve that process. And so hopefully out of this will come something. And if it comes from the Emergency Room Association, because they don't care about NIH, but they care about their own association. If their association puts down guidelines that they have endorsed, then it becomes less likely that an emergency room doctor can ignore it. Because then they can get sued saying, well, this is the guideline that your own association said you should be following. Why the hospitals don't want to get sued right now? Yeah, it's because they're talking. So, yeah. No, I said I haven't. Oh. I thought you asked me.
Yeah, just anecdotal.
From an injury. I'm here at Camp Crescent Moon in the Santa Monica Mountains to talk with the campers about voice crisis alert.
I'm just setting up for on to the next. Yeah. All right, thanks. I'm gonna send you his number. All right, for the fan and the speakers. Well, I'll take a picture of it. So. All right. Ready? Ready to. Can you see this one? So, did you already get that in there?
Well, no, so who can ask to confirm that?
Probably ask her later.
Oh, hi.
Hi.
We were gonna switch over to the.
Oh, yeah, the tables, I'm sorry. I just wanted to make sure because we did have a change, we want for Mountain Glen Place 3 tables with 2 chairs at each table.
That's probably easy.
Okay, okay, and then 2 tables at, okay, awesome. In the Truesdale, we have that too?
I'm not sure, we started here.
Okay, 2 tables in the Truesdale with 2 chairs at each table?
I can ask him if he's on the list.
Okay, thank you. And I'll be right here if you need me.
Okay, we do have a question. She got a request about public HDMI capability. It looks like somebody set it up already.
Let me,
So what the HDMI from the... No worries.
maybe just a tick. So that's what I was really actually going to ask you. Call Steve and I'm going to start calling other people. But there's no pressure there.
Okay. She just told me that she wants VGA and HDMI ran in both Truesdale and Mount Olympus. Yeah, I'm already running the HDMI line in Mount Olympus. I'll see about an adapter possibly for Truesdale. Oh, for in Mount Olympus? Yeah, there's like 3 tables in here now. There's like a head table up by the podium and then like 2 tables in the opposite side. Okay. Okay, yeah, I'll regrab them as well. Thank you.
That Adam?
Yeah. They want this microphone, I'll just take that microphone now. So
The one from in here?
yeah, so I regrab that as well. Okay. Yeah.
You switched that input. No, like on the source. Yeah.
Hey, it's me. Hey, are you charging labor to move this mic, or are you adding a second mic? Well, so are they gonna have it at the head table for the rest of the week, or is this room only for today? Okay. Put it on there. Camera. Oh. Well, yeah, it's because it's ran through, like, it would be just as much work to just rerun a new line. You know what I mean? Because, like, the audience mic is in the center of the aisle right behind the projector. So 50 or 25?
Should be.
Right there. Right. Well, so they don't technically want a mic at the head table, they're just going to use it from the audience mic? Oh, okay. Okay. So then we don't need to run anything else. Okay. I think Tamara misunderstood that.
Hello?
Okay, no worries. Thanks. They're just going to take that and use it around. Sorry. This is done.
Wow. Okay, well, they are the ones in the picture, so whatever. Not a big deal to me.
So I guess Adam was just letting you know that they're going to just take that mic and use it wherever, because of how much slack is on.
Right.
Yeah.
Well, that's what you told me this morning, but then you called me again to say they want it like on the tabletop, go grab one of the small stands for the tabletop, so.
Maybe to just leave it here in case they do put it there. So. And then I guess Truesdale can be done, that's not something to do right now, right? That's it tomorrow. Okay.
Is that something Adam was saying, can we just use this, is that enough? Or use PGA to, instead of extra?
I don't know what I told you. I think he was asking if we could just use this. So, because that's mini display too.
Right, and he was asking, he said we had some kind of adapter that would be a lot faster than we were running the whole thing, but.
I'm almost sure they're talking about this thing. But the only reason I put this one in here though is because I wasn't really clear if they needed both inputs at the same time.
Yeah.
Which we can ask about.
My understanding of it was that she wanted both for different.
Oh, okay. I'll grab those then.
Is this the room right here?
Mm-hmm.
Can you open this door for me?
Probably 300 patients, global study. You want to get that study done extremely well. You want to get that study done extremely quickly. You've got the money in the bank to pay for it. And we're going to need help to do this. So that's really why we're here. I would say, just kind of closing the update part of this morning, our company, and I was going to say, our company is composed of Sickle Cell Crusade, but I didn't want to use the term work. But I listened carefully. We're committed. And turn it over to our moderators to really have a discussion about how you can help us, give us ideas about our clinical study, and any questions that you have.
Thank you. So we're just going to sit over here because really this is a conversation between, for all of us. So we don't want to be the only ones talking. We need everyone to hear from you on what it would take for you to enroll in a clinical trial for sickle cell disease. So we know that you have a lot to say on this topic. And we would really like to hear from all of you. We want to know what's in your heart, what, not just the positives, but the pitfalls. Be honest, I promise you, they can take it. Whatever it is, questions, if you want to ask questions about the statements he's made, about the drug itself, but let's really, really focus in on enrolling in clinical trials, because I don't know if you all know this, but our patient population, one of the reasons we don't have more drugs on the market for us is because we don't enroll in clinical trials. It can take years. There was one drug that was very, very promising. They finally shut it down after 5 years because they could not get the minimum number of people enrolled.
And so we've got to get into that. We have to understand why it is that we are not participating in our own cure and what we need to do to change that. So let's really dig into that conversation. So we are limited on time. So if you don't get a chance to comment, there are comment cards on the table. We ask that you please fill them out. They are collecting them in the comment box at their table out there. And she's with GBT. You've got quite a few. He introduced. Grab one of them. Give them your comment cards. Have a conversation with us so that we can break it down to what's happening here. If you are not comfortable leaving your name, you don't have to. But fill out the card and give us your comment. So, just to kick this off, how many of you have participated in a clinical trial in sickle cell disease? Don't be shy. Well, that's far less than half. So I'm going to participate myself. And honestly, it took becoming a research scientist and realizing how hard it was just to get a tube of blood. And it took me, 2 years to collect just a tube of blood for some of the research I was doing in sickle cell disease, that I became more active. So I get it, but let's discuss why. Yes.
So, I haven't probably been in a clinical trial to a certain extent. I probably did something low level. It's because usually they sound qualified. And I never get why. The age is, my occurrences and non-transfusion. I'm not a chronic patient, so that's my issue. It's not that because I don't volunteer to do it, but I'm just not used as a, I don't want to use the word guinea pig.
You don't fit the criteria.
Thank you. I never fit the criteria.
I raised my hand for my grandson, who was part of the baby hug study. He started on hydroxyurea before he was a year old. The reason why his parents decided is, number one, they had faith and trust in the doctor. Number two, he had just had a stroke, so they were scared to death, and they were hopeful that this drug would help. And thank goodness he hasn't had another stroke. He still, of course, is suffering from what happened with that first stroke. But if you don't have a good relationship with the doctor, if there is not trust, and if the doctor is not treating you with respect, well, guess what? You're not going to enroll.
So I think that is a very good segue into the first question up there, which is, if you did participate, those few hands that went up, if you can start preparing why did you participate. Someone, did I see a hand up over here? There's one. Okay. So a few of you that did raise your hand, we'd like to get into that.
Hi. I haven't participated in any studies in particular, but the main reason is because, well, I don't know about them. I don't know how to get in contact with anybody who does know about them. I have researched them like online and everything, but every time that I research it, I always find a study that's concluded. And so then when I do find a study that is, open or something that I can apply to, I email or I do whatever the process is to contact the person in charge of it, and I don't get a response back. Maybe because there's too many emails and whatnot. So I was just wondering, do I keep trying to contact that same, person and whatnot, or I just continue to look for different pathways to find clinical studies because I've had super troubles with the whole sickle cell thing, but it's a constant thing to keep trying and to keep getting answers. And the main thing what she said is you need a good relationship with your doctor to be able to find this stuff or to get a hold of the information. And many of us are just uninformed. That's the main problem.
And just to add to that, I'm not sure how many of you all know about clinicaltrials.gov. There is a site that you can actually go to where open trials that are currently recruiting, clinicaltrials.gov. Put in your search criteria, sickle cell, and you can find them there. a lot of times you might not be getting a direct contact back, but have your physician contact the study and say you want to be, and I think that's something that we need to discuss. Many of us, our doctors aren't telling us about the study, and I think that is one of the major hurdles.
I was just gonna, I think you also should be willing to contact the companies directly. And these companies have a real interest in these trials as well. And so you may be in a position where the physicians that you're seeing are not in the study. They're not even aware of it. But if you become aware of it, it's very reasonable for you to contact the companies and have the company try to help you get to someone who might be able to know.
Oh, you guys.
The first study, my name is Shirley Miller. I work at Carolina's Healthcare System. I'm the program manager for our adult sickle cell program. The first study I did was the pulmonary hypertension study. And the reason I did it is because I've always worked and I've always had private insurance. And I wanted to find out if I had pulmonary hypertension. My insurance company felt that it was a preventive thing and they didn't want to pay for it. So that was my first reason for going to take that clinical trial. I could take it, I could see if I had pulmonary hypertension, go through everything, and it was free and it didn't hit my insurance. So that's what I did. Yeah.
Somebody can comment to that. You know, one of the reasons that people sometimes, I think, can be reluctant to be in clinical trials is that they are afraid they're being experimented on. And the thing I can tell you all from being in this business for 25 years is that there's no real incentive. Companies, companies want successful products. If we think the product is not good, we kill it fast. We kill products so they're going to use it all the time because we see signals that make us concerned. We also typically start drug development in normal people. That's how we started. That's how we started. We didn't even give it to sickle cell patients. We started out in people that are perfectly normal, and we gave them doses much higher than we're doing sickle cell patients. It's very safe. So there's a lot going on. And then the other point I will make is that sometimes people don't even want to get placebo. They want to get the active drug. And they say, well, I'm going to get placebo. Well, quite frankly, you're getting placebo on top of the best cure available on top of it. So if you come into a study and it's well run, you're going to get good medical care. Some are going to get active drug, not all. But the whole point of that is so that you can have a clear comparison at the end of the study that says unequivocally that the drug is better than the best we can do in medicine plus placebo. And you can get a good measure of that. So I just want to emphasize that getting placebo is not a bad thing. It's basically getting what you're already getting. And if you get the drug, you obviously have the potential to get an upside. And even if you get placebo in these trials, at the end, if the drug works, guess who are the first people to get more drugs, get real drugs? The people want to immediately roll those people over. Because the goal really is to try and help as many people as possible.
So my name is Dr. Izzy, and I'd like to shake things up a little bit. There are three things I want to say. Number one, my first clinical trial, I'm from Charlotte, North Carolina. I work with Shirley Miller, and I'm a sickle cell doctor. The first trial I did with my oldest daughter who had asthma was at Emory. And I started the study, and I didn't finish it because the logistics were just too much. So please share. If the issue is logistics don't work for you, the trialist people can modify a study based on what's going to work practically. The second thing is, we all know that there's a fear amongst African Americans about Tuskegee and what happened. You guys need to talk about it. We can't sweep it under the rug and say nothing. And the third thing I wanted to say was, you will trust somebody on the internet who tells you that this drug from Africa works for sickle cell disease. And you will spend your money on it. But there's no research, right? And so we have to make sure that we are being honest with the reasons why. We want to know. Because if that's good for you guys, let's understand why. And if a clinical trial is not good, let's understand why. So we really, really need folks to don't be stubborn and polite. Close the door and let's bring it all out here. You know, let's talk about what the real issues are. If you're afraid of being as a guinea pig, throw it on the table. Let's talk about that. If you're afraid of, you know, it's a white man's drug versus an African drug, put it on the table. Otherwise, we're going to keep talking about this in the next 20 years.
That's fantastic. I was sitting here debating on whether or not I should go there or stay quiet. I didn't have to because Dr. I do think we have to acknowledge the fact that there has been a stigma in our community for a very long time. People like to pull up Tuskegee, and that's the example they give, but there is actually a long litany, a long list of experimentation, and in fact, the physician who dosed with full body radiation was actually awarded in 1990s for lifetime research. Like these things happen, and I do think that is still in our psyche, and we have got to discuss it. We have a lot of hands up, and I do think that we need to go around and really put these things on the table.
Thank you, Dr. Iffy, for going there. I was going to say my child benefited from a trial that had concluded about a year prior to his diagnosis, and that was the penicillin trial. And the reason why I bring that up is before we consider why we will or will not participate in a current trial, let's embrace what we've learned from the past. I had the benefit of the fact that the principal investigator of that trial was practicing at the hospital where my son was diagnosed, Dr. Marilyn Jackson. So I think we need to realize that there's things that we can learn by embracing that aspect of the scientific method, despite all the egregious excesses of the past. But Tuskegee was for 40 years, but it ended 50 years ago. So I think we need to move on.
Oh, Jenny has I'm sorry.
Okay, I do believe and I do understand the value of participating in clinical trials, but I'll be honest with you. I'm 73 years old, and I have fought a lot of battles along the way. There's not much that has happened that I don't understand. And I think that I suffer from exhaustion, so therefore it's a lack of support system, and various health issues. I've got to go to this doctor today, this doctor tomorrow, 2 days between that, whatever, someplace else or whatever. And frankly, I'm just tired. And so, you know, I can stay home and I'm not bothered by anybody. But then I'm thinking, well, wait a minute. You know, I'm not sure at my age how good this is going to do me. It might, but I understand that's not the overriding factor. But it's the exhaustion and one thing after another, you know? So, for instance, I've had both shoulders replaced, well then at different times. So therefore, it took 2 years to get on the first shoulder. Then I got another one, the other one. It's just one thing after another, and serious issues. That's why I have this.
Hello, my name is Crystal. I'm from Atlanta. I'm a patient and a caregiver. Me and my daughter, we both have MS. And we've done some clinical trials. And I guess my question is, we never know what happens to the research. Like, we never know, did it work, did it not work, what's going on with it. So we've done, I think, a vitamin D with you before Dr. Iffy and a couple of other clinical trials. And we just want to know, like, what's the end result of what we're doing?
I'm going to answer Mike because I'm guilty of that. So we did the first randomized trial on high-dose vitamin D for sickle cell disease, and the outcome was to see does it improve your number of days of pain. And the results show that those that got the vitamin D, they had fewer days of pain compared to those who didn't get the vitamin D. And the results were published at national meetings, in the research papers, but we did not come back to the community and tell them what the results were. I take ownership for that. I blame myself for that. Now, soon after the results came out, I let them read, so that's probably why. But I should have made an effort to at least go to the foundation and say, hey, this is what the results show. Now, most of your doctors are giving you vitamin D as a direct result of that sentinel study. So in some ways, you get it, but you get it third or fourth hand. But I agree, we need to make sure that we take the results back so that people understand this is the value of what I participated in, and this is how it's helping the sickle cell community.
Yeah, and I think even individually, so you participated in one. It would have been nice if the doctor or the company who did it called you and said, hey, thanks for participating, here's the result. Like, I mean, if I got a phone call like that, next time someone asks me to sign up, I'll definitely sign up, you know. And thank you goes a long way.
Will a letter work? Will a letter work?
Yeah, a letter too.
I was going to say, I think that's really good feedback, and we're going to see if we can do something. The companies don't have your information. They're privacy laws, so we actually can't write you directly. But I bet we could set up something to try to do something. I think it's great feedback.
I think people are worried about when you sign a consent, your data is supposed to be confidential. And so what you're feeling is we don't know where that line is, so we don't cross it. But I think a global letter to everybody who participated, or to everybody in your practice, you know, because you may not be able to target those that enrolled, because then it will look as if you're not everybody knows who got the letter, who didn't get the letter. So it may be everybody that is in that practice gets a letter saying this is the result of that study. But
I'm Reverend Alberta Cook from the Charleston, South Carolina area, and I've been working with sickle cell for 43 years. I just made it a life issue. It's very important for the researchers to understand that the persons that you want to participate may not fully understand the value of the research. Sometimes there's history regarding the institution where you're working, and we need to do the history, because you have people, family members who are still alive, you know, who repeat issues of being researched that are not treated properly, or researched just for the purpose of being researched and not giving value. It is important that participation increase, but we all have to understand and look at each other's background and what is required in order to make sure that we get that increase.
So what I've heard so far is we don't know about them. You're not providing enough resources. I'm just exhausted. And these are a little bit of, we might not trust entirely that what you are going, that we don't completely trust the integrity because of previous historical experiences. And so these are a lot of the things that I'm hearing coming from you all on why you would not necessarily want to. I'd like to continue discussing that, but I'd like to add to that conversation, what would it take? What resources do you need? What do you need to happen in order to start to change those opinions?
Hello, everybody. My name is Velvet, and I'm from Oklahoma. I'm the founder and chairperson of the only community-based organization in the state. And I'm a parent. So when I think about putting my child in a clinical study, some of the things that I want to know is how is it going to affect his growth? I don't get that information. I want to know, are there any mental health risks to this? I'm not getting that information. And a lot of things, I think as parents, sometimes as a parent, you feel like you don't want to make that decision for them. You want to kind of wait till they get of some age to say, yes, they want to participate in that, because you don't know what's going to happen in between. But I think if I had more information of, you know, it was safe for him to participate as he grows with his body and things of that nature, and that, you know, there aren't going to be any kind of mental health aspects to this, I would feel more comfortable saying, yes, I could allow him to do that.
I signed up to be a part of this study at NIH. And what made me decide to go ahead to do the NIH study is because the lady was very knowledgeable about sickle cell, and the lodging was provided, the transportation was provided, and they also compensated you. But not only that, when it was time for me to get there, I got sick, and she said, you know what, honey, we're going to reschedule you for the spring because I know the cold is a sickle cell friend. So the fact that they were well informed on sickle cell, and it made me feel like I mattered. Me, this one person mattered to this big study where they take the time to reschedule it, is what made me think, oh yeah, this is something I should do. So I think the feeling that you get from the study, and I think transparency needs to be there, because if there's a lot of unknowns, people aren't going to want to do it.
So I think the first clinical trial I was ever involved with was done in the first bone marrow transplant for a child with sickle cell disease. And that was 30 years ago, no, I guess 25 years ago. And so now I am actually on another clinical trial for sickle cell disease using gene therapy. And one of the things that we're doing now is that the trend for clinical trials is to have what they're calling a patient advisor. And what that is someone who has actually lived with the disease. And we're brought in to help design the study. And so we're able to tell the scientists, if you, for example, are working with someone with sickle cell disease, we are able, so we say things like, all right, well, you have to understand that during cold season, what's going to happen? You have to, if you are going to require frequent checkups, you can't have them come on Monday, Tuesday, Wednesday, because you have to give them a day of rest. You have to provide for their caretaker. You have to look at parking. So all of these things, you know, when they come in, you can't have the room too cold, because science, good science, is very, very expensive. And so the goal is that the scientists are now being able to really see of having a patient or a disease advocate, is that it's a good investment for them. So what happens most of the time with failures of the trials is that the people you're studying drop out. And so I think that now that trend is really, really spreading, and as patient advisors, we're trying to get an international movement going so that all clinics everywhere, but I know here in California we are leading that trend. So look at those studies now, and we have an obligation to be there and participate. We really do.
Hi. So I apologize if my comments are repetitive. I'm going to step out for a bit. But I wanted to speak about sort of the tips for addressing these issues and increasing sickle cell patient participation in clinical trials. Because as a consultant, I've spoken with people at medical centers, people who are clinical study coordinators, and people at pharma companies and community-based organizations. And everyone's trying to pass the buck to somebody else. So if I talk to a pharma company and I say, well, one problem in sickle cell overall, in general, is just isolation. Because if you're in a family of carriers, or just people who are unaffected or affected differently from you, that can be very isolating. And if you're now also going into a clinical trial and no one else in your family or group of friends is doing it, that adds a whole other layer of things that impact your life that you have no one to really speak to about it who gets it. So one great thing would be like a study buddy program. And when I brought that up to a pharma company, oh, we can't do that. There's FDA regulations. We can't do it. They're going to think we're promoting the drug. If I talk to a CBO, well, we don't have the resources. I think the medical center should do this. And medical centers say, well, no. So we're already, giving people medical care. We can't be expected
do everything. And I think everyone has valid points, but it would be good to see everyone trying to do whatever little part they could do to support these things, rather than waiting on some group to take it all the way over, you know what I mean?
Excellent points.
Hi, I'm Sabi Butler-Jeter. I'm actually a community health worker in the state of Georgia. One thing I wanted to say, Lakia, to you when you say that we need to participate, you're absolutely right. But one of the things is with sickle cell clients, patients, however we want to decide to call them, us, we need visibility. And what I mean by that, that means Symposium need to link their websites, and on their websites they need to put, if you're interested in clinical trials, go to clinicaltrials.gov, because believe me, when I sit down with my clients, they look at me like, what are you talking about, and where can I get that information? So what I've started doing is emailing them, but I've asked my CBO, my direct CBO that I work with, I need this on the website. So when they search the website for bow lips and Sickle Cell 101 and Sickle Cell Warriors, we need to see that link on your website. So that's visibility. That's the first step, to even get people to know what's the website, how it works. So that's a start.
One of the things that happens, and it's not really about sickle cell disease, it's about clinical trials in general, in that we are very much underrepresented when it's about heart disease or cancer or whatever. So therefore, first of all, the idea of clinical trials isn't talked about in our communities. And second of all, there's really this gap. I mean, you wanted people to say the real thing. Who works in the hospitals and the universities where you're going to do a lot of research? I can't talk about other parts of the country, but here in LA, it's white doctors and white patients. And our patients don't go to those doctors, don't have any connection with those, so they're not offered a clinical trial. They wouldn't have any idea, and I know what I'm talking about. I'm part of the IBC at Cedars-Sinai Hospital, and trust me, ain't none of those folks looking like us.
My name is Dr. Trevor Thompson, also an individual living with sickle cell, CEO of the Sickle Cell Foundation of Tennessee. And when I started thinking about how we were successful in the Memphis area when we were doing various trials and pieces, it goes back to what other people were alluding to, was that incentive piece. The hospital's getting money, you're getting money, the CBO's getting money, and we would actually distribute that money to make sure that the clients were receiving some type of stipend or something of that nature. I'm not interested in a study where I worry about my life's about to be cut off, housing issues, things of that particular nature. So I'm just putting it out on the table. That's just being real. So, you know, and I know directly sometimes the pharma companies do not get it directly to the patients, but they can do it through the CBOs. Can provide incentives, so we have to make sure that we're accountable. And what we did was provide the same type of atmosphere where we were at the Peabody or something of that nature, where we did those trainings of explanation, ask the hard questions, and treat the patient or the clients with respect. So that's another piece. And both of my great-grandfathers were in the Tuskegee syphilis experiment, and it's long overdue. So if I can say we've gotten past that, you know, definitely we've gotten past that. But it just goes back to education.
I would just like to encourage you all, the same I do with every single drug company that I ever speak with, is go to the CBOs. Do not underestimate the importance of these community-based organizations, because that is how you get to the patients in our community. We are getting our advice from each other. We are learning and taking cues from each other. And that CBO is your best friend, because if you do not involve the patient initially, what ends up happening is what we have seen a lot. I think hydroxyurea is a very good example. The study came out and it was here, this is what we made for you. and it's underprescribed and underutilized, and the community is sharply divided. It's my lifesaver or it's the devil, but there doesn't seem to be any in between. I truly believe that a lot of that could have been avoided if not just saying, I made this for you, but I made this with you, in mind, with your advice, with your patient panels, and you told us what you wanted and how to go about doing it.
I was just going to mention, there's a lot of bad news. I want to just mention a couple of things that you guys may not be aware of, but I know to be true. One of the problems in this is that nobody was really putting money at the problem. If you look at the 1990s and ask how much money was spent on trying to develop a great therapy for cystic fibrosis versus sickle cell disease, you guys know this. The numbers are about 1,000 to 1. Yeah, just disease is 5 to 6 times more common. And that wasn't an accident. So the good news is that's changed. You have people like me who are getting the biggest investors in the world, like Fidelities and Wellingtons, to give massive sums of money to us to do this. I would also say you have people like me now in these companies that actually care about black people. I care about black people because I'm a black people. And, the last thing I'll say, and this you may not know, but you should realize the FDA is very concerned with this problem. They are embarrassed. I have had very senior people at the FDA say to me, it is a national embarrassment. So they are very motivated to help us in this area, but you have to have good science. You have to have smart people who are really focused on going innovative things. And two, the comment earlier about safety, we are so regulated. I mean, we can't go into kids until we demonstrate a lot of safety in both animals and adults. And I would say that we're thrilled to get into kids because we actually are hopeful that if we get into someone young enough, they'll never sickle. And they'll have a perfectly normal life. We can't put it into people that are 9 months at this stage. But as we accumulate more experience in adults, and we're now going down to 12 years old, we've just been given the green light by FDA to go down to 12 years old. Because so far, the most serious side effects, the most common side effect that we've seen has been headache. And that's actually been more common in the placebo group than in the active treatment group. So we don't think the drug's causing that. We have seen a couple of rashes, but they've been mild. It's been a very safe drug, so I'm hopeful that we're getting there, but we do have a lot of things going right for us now. So I think the time is right for us to be, if we can enroll in trials, we can be encouraging our peers and our colleagues to enroll in trials to make something great.
Hi, yes, my name is Joelle Darvadane. One of the founders of Bold Lips for Sickle Cell. So again, our community, we learn from each other. We talk to each other. We get advice. Social media is everything right now. That's how we got our start. We went viral. And we just did a survey. Told people to take a survey for Sickle Cell. And we had over 100 people just by posting it on social media. So we need those communications between y'all. Let us know so we can let our people know. Because if I hear it from someone, I'm like, all right, cool. But if I might hear it from Dr. Iffy and me and Dr. Iffy ain't cool, that's how we are.
I want to add another layer to that. And consider that the CBOs have access to the patient and not to undervalue their work. And I mean that not just for what they can do, but I do mean that financially. The CBOs actually deserve to be supported. And as all of the funds are going out, the CBO has to also maintain itself. I tell all the CBOs partnered with the consortium, do not undervalue your work. When they're coming to you saying, and you guys can hear this, as I tell them,
When these pharmaceutical companies come to you, we want you to do this, that, and the other. Remember that you still have to support your organization. And the pharmaceutical companies can assist with that. And I tell them that because we do get pharma companies that come. Put this on your website, do this, do this, do this. We want you to do this, do this, do this. And offering no support. So I tell all the CEOs, and I'm saying this to you, do not undervalue your work. And don't undervalue their work. Because they really are the gatekeepers to this community.
So I'm going to give people who've had their hands up for a little while. I don't want to ignore. So you're going to be second, you're first. And I'll get to everybody as long as we have time.
Hi, my name is Lisa D. Touré, and I'm the Executive Director and Founder of Atlanta SCAR. And I wanted to share because I recently had an incident where I was asked to allow my son to be a part of a clinical trial. It was an inpatient trial. He was admitted for crises. And I wanted to share that it's how the information is delivered, and I had to weigh the pros and cons. And after listening, I was kind of, I said, give me a moment, let me think about it. I'll get back with you. And it wasn't the things that we've already discussed. It was the doctor that presented the opportunity to me, to us. I wasn't familiar with that doctor. His doctor had never mentioned the study to him, or, of course, I guess being an inpatient, that wasn't possible. But nonetheless, it was the way in which the information was presented to me. And one of the last things that made me say no was he said, well, we're doing this research study with sickle cell patients, but down the road it may help other patients, and that kind of, that the guinea pig, that's what made me go, oh, see that right there is what led me to say no.
So I heard two things. One, it's the person who came you didn't know. And then two, your son's condition was not the focus, the main focus of the study.
Say while she's going over there, I would just encourage drug studies and you all companies when you're designing your study. I personally don't think asking me to participate in a trial while I'm in crisis is the best time to do that. And I think an argument could be made for how ethical that is. Because when I am in that kind of pain and you say this cyanide pill is going to stop your pain, there's a good chance I'm going to swallow. So I do think that that's something that needs to be considered. And that's just, I don't think that is something that should be happening. Talk to me at my last visit and tell me your next crisis. Do you want to be in this trial? Don't come to me while I'm in that hospital bed. Yeah.
Great to be with you. My name is David Max III. I'm with the Committee of Ventilation Assurance Sickle Cell Anemia Program out of Charleston. The middle of next month, I would have been with them 40 years. And matter of fact, Reverend Cook, who spoke earlier, hired me right out of college. But I started as a counselor, doing community organizing, getting the community involved. And I remember one time back in the early 80s, they had a situation in which the DHEC, the Department of Health and Environmental Control, the state legislature gave our sickle cell program $100,000. They gave cystic fibrosis, which affects primary whites, $100,000. And they just took our $100,000 and gave it to cystic fibrosis. Just took it. Now, we were able to fight to get it back. But later on, to show you how things work, I now serve in the state legislature. This is my 20th year. Started working in the community. And guess who has to come before a subcommittee that I chair? Health and Environmental Control. DHEC. Now, I'm not saying that, I say that very humbly. I'm not even smart enough to plan that off, much less pull it off. But from my standpoint, God is the perfect navigator of time and circumstance. It happens. But I think the key from that is that the work that we do here is so special. Now, I have a business, I do a radio show, I do a lot of different things, but the point where I decided I was going to give my life to sickle cell, when my sons were small, I came home, I watched them sleeping, they were healthy, that's when I made a decision, an emotional decision, that I will always be involved with sickle cell. Now, it's a situation with the clinical trials. Very quick. One of the things I think we need to do, and I sat there and heard some very good recommendations, things that should be done. But one of the things I think we should tell these entities when they come in, they need to hire somebody specifically to interact with the community, to sell the community. Because the number one reason people buy things, and I do sales training, the number one reason people buy from anybody, because they like it. Because they like it. And that person needs to have empathy, they need to come in, they need to listen, they need to know the points that were made about the temperature of the room, about the financial situations, about other situations that none of us in this room can even think about. So that needs to be done. It can't be a researcher. Researchers, they're too busy doing what they do, and a lot of times they're not wired to do this. They need to find somebody specifically to come out, interact with the community, sell this, be there for the community, and take input as to make this thing work. Yeah, this data is important. It's critical, but it has to be done the right way, and it has to be done with community input. Thank you.
Now, 10 minutes left, so I'm going to try to quickly get folks. Please keep your comments short.
So, I mean, I feel like the main hurdle is when I go to the doctor, every time that I have a doctor's appointment, I'm feeling completely fine, and there is nothing wrong with me because I'm working out, I have my nutrition, I'm Gucci. So, and then once I leave, and I'm good for, however, a month, 2 months, 3 months, or a whole year or whatever, and then something finally happens. And then I can't get to the things that I need to get to, like the clinical trials or whatever, or I'm in the hospital with a doctor who doesn't know or understand, or how a white doctor, if I may say, or I'm not participating with a black doctor, or my black doctor ate in today instead of doing rounds, so I can't get to that. So it's like, sometimes when we go to the doctor, it's like we're perfectly healthy, so they don't mention this stuff. They just say, oh, okay, well, you're looking good, your labs are good, so you're fine. Get on out of here. But we're like, no, it's not like that. We still need to know and understand, and we still need to inform our family members and our significant others what's going on so that they can do the research too when we can.
And I think that's a role for the CEOs to interact with the healthcare system so that your regular appointment is structured in a way that you get the information whether you're sick or not. Doctors are pressed for time, 15-minute appointment, 30-minute appointments, but if you have an arrangement where when you come and you're well, this is what we do. I think that will kind of address that.
Is any consideration being given for studying the financial burden that is placed on our shoulders through no-fault hours? And case in point, when you become, 65 or whatever that magic age is, you get Medicare. You say, oh, Medicare will take care of everything. You need supplemental insurance. You pay a lot for Medicare insurance. Then you pay a lot for almost the same thing for the supplemental insurance. And then when you go to the doctor, they now have a copay. So my point is that while you're studying the sales and everything in your company, trying to understand us, this is one more thing. Now, there are some foreigners countries that are, they do better by their sickle cell patients. Because, listen, they didn't do anything wrong. We didn't do anything wrong. We didn't go out here and cut our arms, and then, well, if you hadn't done that, well, that was not happening. And so there's a financial burden there that from patient to medical profession, whatever, you need to read my book and certainly.
What's the name of your book, ma'am?
Living with Sickle Cell, a Disease, the Inside Story.
You all heard about the inside story, living with sickle cell disease. All right.
All right, I'm Dr. Cantor, and by the way, I'm white. I'll tell you one of the first times I walked into a sickle cell conference, and I looked around and I kind of said, where are all the white people? And I'm serious. But there are a lot of doctors like me, and trust me when I say I sweat sickle cells. Because this is what I do, it's what I'm committed to. It doesn't matter what color I am or what God I believe to. Yes, the Jewish problem. but there are, just like anybody else, right? It doesn't matter who you are, it's what you do that matters, right? And I don't want you to forget that when someone does come to you about a child. But what I really want to say is, how many people in the room know what an IRB is? That's good, that's impressive. A lot of people that I come to when I go to talk to you about a clinical trial have never heard of that. It's what keeps you safe. It's the internal review board, and it's sometimes called the ethics board. There's all kinds of different names for it in different hospitals. But that's who reviews every trial we do. And one of the things that's important is there's actually limits on what they let us do in terms of compensating patients. We are very strict about, we can't bribe you. I'd love to tell you that I can pay your light bill if you'd be part of a research trial. Just because I think both things are important, right? You need the lights on, and I think research is important because it's going to make you better. But just know that there are a lot of restrictions placed on us. But on the flip side of that, those restrictions are what's keeping everybody safe. So when you see that 25-page consent coming from you, because it's miserable. If you haven't done a research trial yet, and somebody hands you the consent, it's like a little book. It's worse than buying a house. It's really thick, and it's because all that safety stuff was in there to protect everybody. Because of what happened 50 years ago. Because we are going to prevent that from ever happening again. So just so you know, there are restrictions on every single thing all of us do in the research side to try to help.
This is a very fantastic conversation that we're having, but I do want to just let you all know we've got about 3 minutes left. So very, very succinct comments, and then we'll wrap up.
Hi, my name is Maddie Robinson. I'm the founder of Micro Maddie Consulting. Didn't introduce myself last time I spoke. I had a point that I just haven't heard anyone speak about yet, which is the residual effects of the United States eugenics program in coloring our medical system and how that uniquely impacts sickle cell patients because they're also often minorities, also often perceived as having learning disabilities, which people with learning disabilities were singled out under the eugenics program. And we aren't the only population dealing with these later effects now because it was never systematically dismantled and taken out of the medical education. So myself, I've studied science, molecular biology, microbiology at the collegiate level, and also human genetics and sickle cell research at the PhD level. And every level, I went to medical school courses at a major United States university, and when they used sickle cell as the example for genetic inheritance, as they almost always do, it was these people are just so severely affected, they never can contribute to society, they can't hold down jobs, and they almost always end up addicted to drugs and die early. And if you're educating a young person who likely has never met anybody with sickle cell, because let's face it, the people surrounding me in those classes did not look like me. And that's their first education on this disease. I'm not surprised when you go out into the real world 5, 10 years later and you're seeing that play out in how they interact with patients with this disease. So that you know, and how it plays into their just existing biases just from the society we live in too. So that was my main point.
I'm not going to touch that one.
Sorry, Bill. That was one of the last few minutes we had, but I do encourage everyone to your comment cards. Please fill them out. This has been a fantastic conversation. I lost the co-host. We are very, very excited, and thank you again, Global Blood Therapeutics. I hope that you all got a lot of information out of this. I encourage you all to continue this discussion, to continue thinking about how we can do this. Use the comment cards, come up to GBT, and talk to others, because other people need to hear this as well. Other groups that are here, we have representatives from multiple pharmaceutical companies. Find them, talk to them, because this is a conversation that we need to have. Thank you. Let's give them a round of applause. So now we want to encourage everyone. We did run quite a bit over, so we will just go out and get started at 12:30. That's 2:30. We're going to get started with the first panel. So I want to let you all know that we're back in Mount Olympus for the professionals roundtable, and then in Mount Olympus will be right after that the couples roundtable, and parent to parent will be in Trudell State. Aging well with sickle cell will be. These are the breakouts, so they're going to be looking for agendas. Some of them are going to occur simultaneously, and you can see which room they're in. Thank you.
Comment cards, please. Don't forget to write your name.
Yes, ma'am. Nice to see you as well. Where were we last time? We were at the building. I was trying to remember. I was like, what city was that? Yeah, it's nice to see you as well. And your little face are precious.
And helping you pay your light bill, because we got these documents